Hi, it's Dr. Shiller, and this video is meant to answer a question that many people ask. They call my office and they say, hey, I hear you do integrative pain management. That sounds very interesting and important, but you're not in my area. You do telemedicine, but does that really work? Can you do a telemedicine pain management consult? Don't you need to see me in person? And the answer is that there's a lot of value potentially, and I want to explain that to you, and that's what this video does. But first, I just want to acknowledge the intelligence of the question, because if you think about it, most people think, okay, pain, I hurt my knee, I hurt my back, I've got a neck injury. I want someone who can put their hands on and see what's going on and examine me and see what's happening. And it's important and it's useful. A hands-on exam is a great thing. I do that. I do an extensive exam with people in my office. But the fact is that pain and chronic pain is a much broader and more complex topic, and that most of the time, if you go to a pain doc who's is doing the hands-on thing, but is mainly just prescribing meds or doing injections, they're missing this whole complexity picture. They're missing the systems biology aspect of pain. And in so doing, they're missing a lot of therapeutic leverage and potentially missing out on what can really help you. And so the integrative approach that I take is really about looking at the whole you. I want to explain a bit about what that means and why it's so important that it might even be worth me not being able to put my hands on. So let's just unpack this a little bit. I'm going to share a few slides. The whole idea is to illustrate. I'm going to go through them a little quickly. I've talked in a lot of detail about these things in other videos. So if you want to see more detail, look at my YouTube or my blog and find those more detailed things about why does chronic pain happen. So first, let's have a look at the first slide here. And what you see is a schematic of the pain processing system. This is from Scientific American from a bunch of years ago. The main thing this is here to illustrate is let's say you have burning in your hand or an infection or something that generates pain. We call it stimulates certain receptors called nociceptors. It sends a pain signal up certain fibers in your nerves that go to your spinal cord. There they talk to other nerves and send the signal up towards your brain. And then when they get to the place called the thalamus in your midbrain, they send the signal to other receptors. So it's like relay. The baton is passed. And the signal actually splits at a certain point, and one part of it goes to the part of your brain that says, ah! The other part goes to the part of your brain that says, in a very much more sort of discerning way, I've got burning, intense stimulation in my hand and it's unpleasant. So the point is that you have a pain processing system, that these places where the baton is passed from one set of nerves to the other, and again, it's not single nerves, it's thousands of nerves. This is a wave of electrochemical energy flowing up from the hand to the part of the brain that says, ow. And it's modulated by a lot of things. And we call that your pain processing system. And it's like there's signal processing at multiple levels. It's almost like there's an amplifier in the spine of the brain. It can turn the pain up or turn the pain down. So let's unpack what that means and why it matters when you're trying to deal with chronic pain. This is the basic idea I just shared with you, that you get something in your tissue. Maybe it's an injury or degeneration or inflammation or a burn, and that sends a nociceptive signal through pain processing that comes to the place that says ow. And let's unpack pain processing very briefly. I do this in a lot of detail elsewhere. So the basic point of this slide is just to point out that pain processing is profoundly influenced by your emotional and mental state. We know that from tons and tons of research, that negative emotion without purpose and a state of hyperarousal, overactivity of that fight, flight, freeze response, which is part of the autonomic nervous system, that's what drives this whole thing. Perceived pain, emotional distress, beliefs about pain, it's a vicious cycle. They amplify each other. The caveat is that purposeful pain is different than, gosh, I'm suffering pain. And the emotional distress and autonomic arousal amplifies pain transmission. The next part is what you might sort of loop together and call metabolic disturbances. There's a whole bunch for them in this circle. Things like inflammation and oxidative stress and nutrient deficiencies, hormone imbalances, which can come from chronic pain, and chronic autonomic imbalance can disturb not only your adrenal hormones, but your sex hormones, which can have a huge impact on pain processing and transmission. Gut dysfunction, leaky gut, intestinal permeability, Dysbiosis can actually create systemic inflammation, can result in producing chemicals that kind of mess up your brain and create more anxiety and emotional arousal. The point is that all these different metabolic variables are all related to each other, vicious cycles typically driven by the autonomic nervous system and sympathetic hyperarousal, overactive fight, flight, freeze, and that can amplify pain transmission. So looking back at this and getting a big picture, we talked about all these metabolic issues that can drive pain processing. We talked about autonomic imbalance or overactivity, that stress response, which itself can drive increased pain transmission, but also can drive all of these physiologic processes that can increase pain transmission and feed back into autonomic imbalance, because basically your body experiences inflammation, oxidative stress, toxicity as danger, and it can stimulate your autonomic nervous system. So this is a whole set of vicious cycles that can worsen pain, and it's not just about that structural thing that happened to your body. It's about secondary changes in your mind-body system and your metabolic system. Other aspect of the mind-body system, like we talked about, beliefs, emotion, meaning. If you're experiencing hopelessness, shame, blame, guilt, frustration, anger, loss of life force, loss of meaning and purpose, amplifying autonomic imbalance, feeding in potentially all to these metabolic disturbances, amplifying pain transmission. And then where it gets really complex is that these same biological changes can feed into other diseases, and these other diseases can feed into these biological changes. So whether it's other chronic pain that you had before, or diabetes, or gastrointestinal illness, autoimmune disease, anxiety, depression, neurodegenerative diseases like Alzheimer's, Parkinson's, all these things are connected with each other. There are underlying physiology that drives these diseases, and these diseases drive this underlying physiology, and that can be driving the whole pain processing issue. Next step to think about is just behavior, and whether you're doing self-care or self-destructiveness. Like self-care behaviors are things like reducing autonomic imbalance with meditation, or doing things to enhance your diet and reduce inflammation. The self-destructive things could just be eating comfort food, like sweet, yummy, creamy, high carbohydrate foods that feel good but drive inflammation, drive gut dysfunction, and can feed into these problems. And even worse than that, substance abuse, whether it's tobacco or alcohol or harder drugs that you might feel like you need in the short term, but really what they're doing is making your system sicker and feeding into the pain in the long term. So you take all of these relationships that are complex, all these different systems talking to each other, feeding into pain processing, feeding into biological mind-body imbalances, metabolic imbalances, and other diseases. And like that leads to the loss of life function that happens with chronic pain syndrome, whether it's I can't do stuff I care about, or full-on disability, not being able to work, losing life roles like I'm a worker, I'm a husband, I'm a wife, I'm a parent, I'm a civil servant, whatever it is, what gives you meaning when you can't do that stuff. Loss, breakdown of relationships, falling into hopelessness and depression, losing a sense of purpose. This is what the suffering is. The suffering is this whole big picture. Notice we've come a long way from just an injury on your back or your neck or your leg. This, to varying degrees, various aspects of these kinds of dysfunction affect most people with subacute and chronic pain. Certainly the people who are thinking about consulting me are frequently ones where the usual medications and injections haven't really worked. And so they're already in this complex realm of all these different things going on, driving the suffering. And so just summing up, pain processing has a lot of variability, a lot of different things that can turn it up, turn it down. Things that can turn it up are things that we can actually address, like autonomic imbalance, metabolic changes in the system, emotional and belief, meaning, behavioral changes, life dysfunction. It's all vicious cycles. The event that caused pain can trigger a whole lot of biological changes that over time worsen the pain. And so summing up kind of my response to the question, if you've got a really simple pain problem and it's just your knee pain and nothing else is bothering you, then great, get your knee treated. go to the best knee person you can find. But if you've done that, if you've had some sort of incident or event or illness and the pain isn't going away and you're starting to notice other things are going on, then what often means is you're having a broader problem, and you want someone who's going to be able to think about that broader problem. If you can find an integrative pain doc in your area who can also examine you, go there, see that person before you see me. That's fine. Where I come in is if you don't have someone who can see you face to face, who also has an integrative perspective, who can address this broader aspect of what's really going on and driving the pain. So let's talk about a few cases. These names have been changed to protect my patient's privacy. Francine is someone who was in their 60s who came and saw me with symptoms of neuropathy, burning in her feet, burning in her hands, wasn't able to sleep, had overwhelming pain. She felt it was cruel. She couldn't deal with it. It was really messing up her life. She was told her labs were all normal. She had a negative EMG and nerve conduction. The neurologist said, here, look, take this medication and learn to live with it. But the medications didn't work, or the other medications worked, but they made her all fuzzy and foggy, and she couldn't do what she cared about. So she called me up, and we looked at her, so to speak, normal labs and found that things weren't so normal, right? Like she had a borderline low vitamin B12. In someone with neuropathic pain, that is not normal. And we checked something called a methylmalonic acid, which is a way of looking at how well the B12 is functioning. And hers was high, which means her B12 level wasn't enough for her. There's a lot of variability. We make assumptions that normal is normal for everybody, and it's not always normal for everybody. Vitamin D was very low. Vitamin D is not just about bone health. A lot of docs still think it is, but it's a prohormone. It affects pain transmission, it affects inflammation, it affects gut health. A lot of those metabolic factors that we were talking about, which can feed into this increasing of pain transmission and pain sensitivity, are influenced by vitamin D. Her magnesium was low, normal on her blood test. But the blood test is not a good measure of magnesium because magnesium is inside the cells. To really get a measure, you need to do like a scraping of the cells in the mouth or an intracellular, like a red blood cell magnesium. So we treated her with magnesium and vitamin D and B12. She had an elevated CRP, which is a measure of low-grade inflammation. It wasn't horribly high, like, oh my gosh, she's got a horrible bacterial infection. So her doctor just kind of ignored it. Yeah, sometimes the CRP goes up when people get older. But wait a second, inflammation can make pain worse. So we treated her with botanical products that can reduce inflammation. I treated her with something called low-dose naltrexone, which is an off-label drug that gently reduces certain inflammatory pathways and also blocks pain through stimulating the body's natural opioid production. And she had a borderline high thyroid stimulating hormone. This is a whole topic. I'm not going to go into the details. But when we went deeper into that, like they looked at this and they said, oh, normal thyroid. When we looked deeper into it and also some of her symptoms and something I saw in her physical exam, I was suspicious her thyroid functioning was low. And she actually had low free T3 and she wasn't converting properly from T4 to T3, whatever. I don't want to go into all the details, but the point is low thyroid function can amplify pain transmission. We treated this stuff. Her pain got like 70% better. She wasn't all better, but she was a lot better. She was living better. She was a lot happier. And that was because we looked more detail at her, so to speak, normal lab values. Another case, James, he was 47. He fell on the job, had a really bad fracture in his leg. 2 bones broke. He had to have surgery with a rod and pins. Really tough situation. And he was having this really severe pain. They were just giving him oxycodone and Percocet 3 or 4 times a day. And it wasn't cutting it. It was making him groggy. He had difficulty walking. He couldn't work because his pain would get so activated when he tried to work and do stuff. And the meds weren't doing him well. He was constipated. He was getting depressed. He wasn't sleeping. Had this pain in his ankle going up his leg. He started developing indigestion and belching, irritable bowel syndrome. I see this all the time. After an injury, whatever it is, the pain persists. The body starts to wear down or starts to develop metabolic disturbances like I mentioned before. He was angry and frustrated. So what did we do for him? Well, first of all, from hearing about the injury and hearing about the surgery and asking him really specifically, where is his pain? And I have my people do a pain drawing, like makes little X's on 3 views of his body. So like I saw the tissue plane, the pain was going up. And it's a classic thing where those tissues and the fascia get restricted. And I said, can you press there? And he's like, yeah, that hurts. Can you press? Like he did a physical exam over the phone, over the video. And I connected him with a body worker who I knew who was really good in his area, who did some gentle releasing to his tissue, which was all whacked out from the surgery and the scarring and the chronic pain and that kind of contractile thing that the connective tissue and the neuromuscular responses do. It was a classic picture from seeing 40,000 patients over 25 years. Like, I know the patterns, and so I could connect him with someone that helped that. We also worked on healing his gut, and we did some stuff to help stabilize his really bent out of shape mood, and gave him some LDN in between his acute opioid doses, because you can do that. And again, he was probably 50% better. He had chronic pain for a while. It was years. So the 50% improvement made a real big impact on his overall quality of life, his ability to do stuff with his family, his sense of purpose. He started thinking about what other kind of work he could do. He got back into life from that. And part of it was also just talking and connecting and seeing him as a human being and connecting with his experience and him feeling seen and heard, and me helping him do a certain amount of adjustment through the psychological challenges and teaching him some mind-body techniques to reduce that hyperarousal and to actually activate some of the healing power of the heart for joy, of compassion, and love, which is something I do in some of my sort of like online courses and trainings that I do with people. So this is all via telemedicine. Another person, Jane had a car accident. I saw her a year later. She was having persistent chronic pain in her hands and shoulders and knees. All of her workup was negative. Her biochemical testing was negative. And I checked it and looked really carefully. There's really nothing going on there to explain on a biochemical or structural level. There was no fractures. There was just the trauma, right? But I went deeper into the history. And she later told me, like, none of my pain doctors or orthopedic surgeons asked me all those questions about, are you sleeping? Well, what wakes you? You're not sleeping? What wakes you up in the middle of the night? Well, it's not pain. No, I'm feeling scared. I'm actually feeling scared, and sometimes I'm having dreams about that car accident because I thought I was going to die. I was in the car. I was going through the intersection. This truck was coming right at me, and I slammed on the brakes, and he did, but he slammed. I thought I was going to die, and she was crying, telling me about it a year later. Okay, Jane, so what's it been like getting in the car? Well, I haven't been driving. No, I wouldn't drive. My husband drives me around, but like I'm scared a little bit when I get in the car. One time we went near the site of the accident and I had a panic attack. This is post-traumatic stress, right? This is a conflagration of the autonomic nervous system of the fight, flight, freeze response. So her system was generating sensitivity to pain. It was generating a pain and protective response from her trying to save her own life when she thought she was going to die. We tested her salivary cortisol, which is usually kind of pops in the morning, goes down. Hers was just like up all the time, which partly explained her lack of sleep. And it's actually a fairly typical finding in post-traumatic stress disorder. It started screwing up her menstrual cycle also, because it happens that when the cortisol is chronically up, it shifts the sex hormone synthesis. And you get shifts in things like estrogen and progesterone, which can be involved in motivation, involved in pain and comfort and calm. These are really important psychoactive things. And so the main thing that she did that I encouraged her to do, we did some stuff with some plant-based substances that can modulate high cortisol, some mind-body therapies to help her develop some sense of control over the anxiety, over the tightness, over the right? But she did some deep psychotherapy. Like she had done cognitive behavioral stuff, which really didn't help her that much. And I helped her see that, you know what, there's a deeper kind of therapy, which is trauma therapy. And there's research showing that CBT helps people a lot with trauma, but there's a lot of people it doesn't help. So she did much more body-centered psychotherapy, working with a good therapist who's an expert. And she started working through the trauma. She started working with the pain sensations and the emotions that she was feeling in her hands, in her shoulders, and starting releasing with breathing techniques, with focusing techniques. And it had a huge impact on her pain. and her pain got significantly better because she uncoupled all of that intensive sympathetic overdrive. Okay, so those are 3 cases that illustrate aspects of the complexity of chronic subacute unrelenting pain and how it can affect different systems, and how there's this feedback between your mind-body system, your structural system that may have been injured when you had that injury, and your metabolic system, and how they're all connected. And that pain care that really addresses all 3 of those can frequently help people who haven't been helped by the usual, drugs and injections. So that's what I do in an integrative telemedicine pain consult. That's what I do in my office. If it's interesting and compelling to you, I encourage you to reach out. You could contact the office, or you could shoot me an email if you're on my email list or my newsletter list, and I'd be happy to try to be of service. Wishing you all the best. Thanks a lot.